Good evening, sir. Good evening, everyone. So, shall we start?
Yeah, I'm ready.
Okay, sir.
Let me start sharing my screen.
Good evening, everyone. So, topic for today is cardiovascular CCS, and the faculty that we have here is Dr. Arun Raja Thangavel, sir. Sir, take over. You may start. Thank you.
சந்தோஷம் தான். அதுக்கப்புறம் சித்தப்பா கால்ஸ் வரும்போதே இப்போ ஆடிஷனுக்கு இல்ல என கூப்பிடும்போது ஃபோன் பண்ணி கூப்பிடும்போதே பசுபதி சார்.
Fine. That was not me. Can you hear me?
Yes, we can hear you very well, sir.
Great. And you can see my slides moving.
Yes.
Great. So I've not met you guys before. If you can kindly introduce yourself in the chat, like who you are and what you are doing, where you're working, what level of training you are in, that will be amazing. So we have a nice session today in the cardiovascular system. Myself, Arun Raja. So I've trained from India, but currently working in critical care department at St. Thomas Hospital in the UK. So last year I took EDIC exam after undergoing a training with Farz Academy, and I was successful. And I'm really thankful to the Farz Academy. So I'm contributing back by becoming a faculty and started teaching. All right, let me check the chat. Fine. Great. So others, please feel free to introduce yourself so it's easy for us to interact. It's going to be a really interactive session. Please use this session like exam scenario and make full use of yourself by treating it like a mock exam. So congratulations for clearing the part 1 and becoming eligible for part 2. And you are in really safe hands with Farz Academy. If you go through all the videos and the live classes, definitely I can assure you, you will definitely pass. Yeah. So the objectives for today is orient you towards how the actual exam is going to be. That's the most important part. Theory everyone can read, but just getting the simulation of the actual exam and understanding the exam pattern is crucial to clear this exam. So today we are focusing on clinical case scenario, kind of long case or short case discussion. So I've designed the class exactly like the actual exam. So it's going to be really useful. And I depend on you guys to come up with the answers. Then we can discuss about it and modify the answers and go through the important concepts. And I can help modify your answers according to the exam standards. So few basic rules. Let's keep it really interactive and maximize your benefits by considering this like an actual exam. And if possible, keep videos on. It's not always possible, so I'm okay with that. As you've already set your name as Zoom ID, that's perfect. And I will try and encourage everyone to get involved because it's very important. That's when you take maximum out of this class. So keep practicing answering in a structured way and try to score maximum marks in the exams. And at any point of time, feel free to interrupt and clear your doubts as we go. Happy? So a couple of you introduced yourselves. Thanks, Manoj and John. Fine. For those who have joined recently, please introduce yourself in the chat so it's easy for us to interact. So let's go into, so this is going to be like a series of clinical Vinay of the same patient who has come to ED. He's going to develop how like complications and how his clinical case progresses for the same patient. And at each point, we will be asking some questions based on the scenario. Okay. Maybe I can start with Manoj for the first questions. Okay. You okay, Manoj?
Yes, sir, I'm ready.
Great. So a 58-year-old man collapses at home with sudden chest pain. His wife starts CPR. Emergency services arrive within 8 minutes. Initial rhythm is VF. After a couple of shocks on the site, paramedics scoop him with eye gel in and ongoing CPR. He arrives to the emergency department still in PEA, and you continue resuscitation. 3 doses of adrenaline is given, and ROSC is achieved after like 14 minutes. And post ROSC, his GCS remains 3, blood pressure is 80/50, heart rate 110, SATs of 94 on 100% oxygen, and doesn't have any significant medical background other than like diabetes and being a smoker, chronic smoker. So this is where you are. How do you want to proceed now? So now the patient achieved ROSC. How do you want to go further? Yeah.
Yes, sir. Yeah, so this is a 58 years old man out of hospital cardiac arrest, and he has achieved ROS after 14 minutes of CPR. So I will go with the general approach, first APC approach. So he has a IGL ventilation, and IGL is not a definitive airway. So I would like to proceed with the definitive airway. I would like to intubate him first with the definitive airway, put
Yeah.
him on a ET tube. Then again, I will. So saturation is 94 and FiO1, so that is fine. Saturation part. I will anyway auscultate his chest, see whether any, because it's a CPR, so I should make sure the airway is patent on both sides to not to miss out any pneumothorax or anything, because there can be has possibility of rib fractures. And after securing airway and after securing the breathing part, I will go with cardiovascular system. So BP is 82/50. I would like to proceed with 2 large bore IV lines with noradrenaline support. So I want to give him inotrope support to make sure his BP is above, MAP is above 65. I would like to check whether he's had any Foley's catheter or not. If he's not on Foley's catheter, I'll just place him on a Foley's catheter to monitor the urine output, so that I can get his vital urine output, functional of kidneys. And I will try to draw blood lines. I'll check all the regular routine checkups. I'll do an ABG. I will see whether patient is having any acidosis or not. I will try to get a troponin. I will get an ECG for him to see what is the current status, what is the reason behind his ventricular fibrillation, is there any STEMI or any MI, and I'll try to check his blood sugars in bedside because he's diabetic. I wanted to make sure his blood sugars isn't hyper or hypoglycemia. Then I will inform the ICU. If possible, I will get him an a CT brain to rule out any ischemic component because of post CPR. And yeah, I'll shift him to ICU. I'll do further management in ICU.
Yeah. So that's an comprehensive answer. Really happy with that. So if you give an answer like this, till like the examiner is asking what next, or like if they're expecting some more answers, in the exam, they are allowed to prompt you like, is there anything else you want to add or anything else like that they may ask. So it means that you still haven't answered like few more points. They have a checklist of like, if you have answered this 1 point like that. So if they are asking for it, so they are expecting for something else. Just try and think if you have missed anything again. And other thing is, you answered in a structured way, little bit better. You can structure it slightly in a better way. So this is from the ESICM recent resuscitation guidelines. So it covers actually what you have said. It just puts it in a slightly different perspective, like immediate management, like you said, like airway and breathing. That's what I'm going to focus with the aim of saturation. That is importance, right? Like even if clinically we do follow this, but we don't mention it. So this may carry a point. So that's when it's important to mention. I will aim for SATs of like 94 to 98 because different guidelines give different SATs target. But for this EDIC exam, I think we should go with European guidelines, and it says like 94 to 98. And if you read the document, there are some more targets like PO2 more than 60. As you said on the ABG, you will do a gas. And yeah, as you said, go ahead with intubation, use waveform capnography, and ventilate to normocapnia. Again, you are targeting normocapnia, yeah? So moving to circulation part, 12 lead ECG should be the first thing which comes to your mind. Yes, we do all the intravenous cannulation, thinking about vasopressors. And interestingly, not all centers use peripheral noradrenaline. Some centers actually ban using like peripheral noradrenaline unless they are in ICU with a central line. It's not advised. So we use like alternatives like peripheral adrenaline or metraminol or whatever other vasopressors because of the complication rates associated with noradrenaline given peripherally. So that's one thing to just mention about. And initially they mentioned systolic blood pressure target. They don't address like mean arterial pressure, but later on they do say like a map of 60 to 65 millimeters, as you mentioned. And we will obviously give some fluids, consider invasive blood pressure monitoring and vasopressors, inotropes once we have like definitive central access. And you did mention blood sugar that comes as A, B, C, D. And other thing to remember is if the patient is febrile, try and avoid fever. So this is part of the immediate management, which you can discuss in your A2E assessment or A2E management rather than just ABC. And next comes, as you mentioned, 12 lead ECG is very, very important. Basically in out of hospital cardiac arrest, right? Most important reason for cardiac arrest is we want to rule out STEMI basically or cardiac cause of arrest. So we will rule that out first. If the patient has positive ECG like STEMI or arrhythmia still on continuing ongoing arrhythmias, so we will have to take him to the cath lab immediately. And if not, we will go for other causes like neurological causes, respiratory causes. We will try to pan scan them and screen for other causes of cardiac arrest. So from immediate management, you have whatever you have discussed, then definitive diagnosis, and continuing with your ICU care, we can explain a bit more about it. If anyone want to add, what will you do in out of hospital cardiac arrest? It's not STEMI, but a patient has had out of hospital cardiac arrest. How do you want to manage them in the ICU? Was the next person? John, are you there?
Yes, I'm here. Thank you.
Yes, John, go ahead. So he has come to ICU. This is not STEMI, but yes, had some out of hospital cardiac arrest. If you didn't find any specific reasons, general management in the ICU in out of hospital cardiac arrest, how do you want to proceed?
Well, in the ICU, I would, in the absence of STEMI, I would like to, STEMI as the cause of his cardiac arrests and loss of consciousness. We would like to investigate him more broadly. I'd like to do a request for full blood count, complete blood count, and chemistry panel. Look at check the renal function, the hepatic function, and also request for CT brain to rule out any other neurological reason why he may have had a cardiac arrest.
Yeah.
I think that's the approach, at least for now.
Yeah. So he has had those scans. You didn't find anything significant, and he is admitted to ICU. So how will you? What are your aims? What are your targets in managing this patient once they are in ICU?
Just like was said, this patient is now on ventilator. Will have the hemodynamic or ventilatory target would be to maintain adequate oxygenation and normocapnia. Then hemodynamic goal will also include maintaining a map of 65. And then temperature management. We would like to maintain normothermia in this patient. I'll also ensure that blood glucose is normal. So we'll repeatedly do repeated blood sugar, random blood sugar estimation. Okay. Okay,
Yeah.
and then I'd also like to maybe ensure that he doesn't have seizures, and he might need anticonvulsants. We might also put him on anticonvulsants, you know. And
Yeah. So this questions may look really simple. This is what we do every day in the ICU, but when asked as a specific question, it may put you off suddenly, like, oh, this is very simple. Why are they asking that? But still, we need to say it out and get the marks to pass the exam, right? So again, you can follow a structured approach like A, B, C, D, E, like maintain normoxia and normocapnia, avoid hypercapnia, maintain like a map of at least 60 to 65, normoglycemia, normal temperature. So even few years ago, we were advised to give like targeted temperature management, have mild hypothermia, but now it's completely out. Hypothermia is not mentioned in any guidelines, not advised. So now the trend is towards avoid hypothermia, like avoid temp more than 37.5 or 37.8 based on different guidelines. Not even target like 36. Avoid fever. That is the new guideline recommendation. So that is a significant change based on the recent evidence that hypothermia increases the mortality and increases the complications rate associated because of multiple reasons. And so we didn't mention echo so far. So we did mention ECG, CT brain, but these patients do need echocardiogram, formal echocardiogram, and further decide on whether they need a delayed PCI if it's not in STEMI. And they are at risk of severe hemodynamic instability, right? So they may require some mechanical support devices. And coming to like D and E, they absolutely, as John said, we need to treat and avoid seizures. Have a EEG, even if it's non-convulsive, you need to rule that out. And then comes the neuroprognostication part after that, after 72 hours of like neuroprotection, right? So let's move on. So far, any doubts? Anything you want to discuss more?
What about tox screen, sir? Anything we'll do on a toxicology screen?
If we don't have a definite reason, yes, definitely. But not in this patient. In this patient, I will come back to that. But yeah, we should think about it if we don't find any specific reasons for like,
for ICU admission.
yeah.
Please just prepare, okay? Thank you.
Right. Who is ready to answer the next one? Any volunteers? Whoever can give a go. Yeah, try.
Okay, let me try. I'm sorry, I went off there was some disconnection, so I couldn't
Okay.
get. I don't know if you can summarize the last what you said about the post
Yes.
resuscitation care, the last bit. Then I'll try to take this next one.
Yeah, I was just saying like whatever you said were correct, but you took some time to arrive there. It is like simple things, but we need to say it out in the exam, like because it's really important. We need to mention them like normoxia, normocapnia, normoglycemia, map of 60 to 65, get more investigations, like you said, and avoid seizures. And after 72 hours, we aim for like neuroprognostication. Basically, that's what I said, John.
Okay, thank you very much, sir.
Fine. Yeah, so I was asking for volunteers to answer the next question. These are simple ones. I have a bit more complicated ones coming up, but
Okay.
try your best. Not it's nobody knows each other, so it's a safe place. Nobody's going to judge. This is the best place for you to try and answer. Even if it's going to be wrong, it's absolutely fine. That's how we
Yeah.
learn. Yeah.
That's right. So as at least I can mention two factors that that can be used to predict determining the neurological outcome different. The first one is the GCS, the level of consciousness, and then the presence or otherwise of seizures. Seizures is also, and then persistent pyrexia is also of prognostic value in patients who have had who have just lost consciousness after remained unconscious after resuscitation.
Yeah, absolutely correct. Anyone else want to add anything?
Reflex, poor pupillary reflex, dilated pupils.
Absence of pupillary reflex. Yes, absolutely. Anything else?
Neo-specific annulase or EEG?
Neuron-specific enolase, if it's like high. This is like still in the early phase. So neuron-specific enolase, yes, if it's high, there is a poor neurological outcome. Anything else? EEG maybe
EEG.
24 to 48 hours. This is like less than, if they are actively seizing, maybe EEG may be useful, but not in the early phase. But it definitely has a role in neuroprognostication after 72 hours, definitely. Just think about it, like this patient, what do you think is suggestive of poor neurological outcome or good neurological outcome?
Hypoxia is the reason for his poor neurological outcome, basically, for this particular patient.
So why hypoxia? What factors can lead to hypoxic brain damage? This patient has had like bystander CPR and a good CPR with the paramedics, but what can cause or what puts the patients at risk of hypoxic brain injury?
Duration of CPR.
Sorry, I didn't.
Duration of CPR.
Duration, exactly. How long? If it's like 60 minutes or 80 minutes of CPR, definitely there's going to be some neurological damage, right? So the duration of CPR, that's a really good point. Yeah. Similar terms, what are the poor prognostic markers?
Again, quality of CPR, if you say in that.
Quality of CPR, yeah, agreed.
And there is no definite airway, it is only IGL. Sometimes it may not be inadequate to give full 100% FiO2.
Yeah, again, quality of CPR covers that. Any other basic patient factors?
Pre-existing neurological disease.
Patient is a smoker.
Diabetes, like age, basically. If the patient is elderly, the risk factors are going to be high, right? Poor neurological, compared to a 20-year-old, 50-year-old, or 80-year-old, the outcomes are going to differ. So age is an important predictor of neurological outcome. More the age, poor the outcome. Anything else you can think of?
Myoclonic jerks.
Myoclonic jerks is a yearly poor prognostic sign. That's absolutely correct. So this is what I add. So no flow time, so time taken to start CPR from the arrest. So if it's a witnessed arrest or a witnessed arrest. Okay. So this was a witnessed arrest. The wife started CPR immediately. So that's a good thing. And low flow time. That's the time to ROSC, right? Total duration of CPR. This is another important factor. And if the initial rhythm was shockable, that's a good prognosticating sign. Rather, if it's unshockable, PEA or asystole, that's a poor prognostic marker of poor neurological outcome. And in the initial gas, if the lactate is very high or severe metabolic acidosis is there, that's a poor neurological outcome. And post-ROSC, if the patient remains very unstable, keeps going into arrest, that's again a very bad prognostic marker. And as we discussed, EEG and pupillary reflex. And again, given the caveat that yearly prognostication is not foolproof, so we need to wait for at least 48 to 72 hours to start neuroprognosticating these patients. And Have you heard of this Miracle 2 score before? So, Miracle 2 score is being increasingly used in the UK. Primarily, it was introduced by King's College of London based on a retrospective study based on their analysis of like out of hospital cardiac arrest. And this is the scoring they have come up with. Like a patient unwitnessed arrest gives a point of 1. Initial rhythm is non-shockable, 1 point. Pupils not responsive, 1 point. And based on the age, if more than 80 years, it adds that significant 3 points to that. And a change in rhythm, like initial rhythm was shockable, then degrading to a PEA or asystole, it carries 1 point. And low pH in initial gas carries 1 point. Okay. Just giving adrenaline carries like 2 points. That's really significant. So again, pointing towards non-shockable rhythm and non-shockable pathway of the advanced cardiac life support. So based on this, if the total point is more than 5, the risk of poor neurological outcomes are very high. So sometimes if the risk factors are too high, even if it's like arrhythmia related shock, they are hesitating nowadays. The cardiologists are hesitating to take them to the lab because the outcomes are going to be poor, which makes sense as well. So I don't know how widely it is used across Europe or around the world, but definitely in UK they are using the Miracle score. So this might pop in the exam either in part 1 or part 2. So just to be aware. Right. So another advanced question. So what's the role of eCPR? What is eCPR and what is its role in out-of-hospital cardiac arrest? Any of you have any?
eCPR is ECMO CPR.
Very good.
Yeah, it's increasingly being used in Europe. There, what they do is once there's an alert concerning a sudden cardiac arrest, the ECMO team is dispatched to the site of the arrest, and they quickly site their cannulas and begin the ECMO, before transferring the patient to the hospital. It's been shown that the outcomes of cardiac arrest that was resuscitated by eCPR are a lot better than those that were transferred to the hospital first.
Excellent, John. Excellent. Yeah, you're absolutely correct.
So the important thing for the expertise, if the expertise level is preferred.
Your voice was interrupted, John. What was the last bit?
Okay, no, I'm saying that it's being currently used, especially when the expertise is available, because you need people who can quickly insert the ECMO cannulas in the out of hospital settings.
Yes, true. In tertiary care centers, this is being increasingly used, and this is an active area of research as well. And as John mentioned, there is some evidence that it improves the outcome. So especially these 3 trials, Arrest, Prague, that's in Europe, and Inception. So in the first 2 trials, as John mentioned, they went to the area of arrest and cannulated at the site of arrest sometimes, and then brought them to the hospital. And Inception, these 2 trials were like single center studies, and Inception was like multi-center studies, and basically depended varied from place to place, like how they are cannulating for ECMO and how they are selecting the patients. The single center studies showed improvement in mortality because they have a strict criteria and selected the patients wisely. But Inception trials didn't show mortality difference. But it is being used in multiple centers as more increasingly, as I'm seeing even in my center, they are starting to do the ECMO CPI in selected candidates. And this is the protocol which we are following. So the previous question's importance is this. If the patient is having like early signs of poor prognostic factors is not going to be candidate for ECMO, right? So it's very important to know factors like whether it was witnessed or not, and what was the low flow time. And if the low flow time is more than 60 minutes, automatically they are not a candidate for ECMO. ECMO is very resource intensive and expensive, right? So not possible in all the centers for all the patients. So it's possible in some centers like in Europe or UK where it is publicly funded. So it makes emergency decision making much more easier rather than waiting for the patient to approve like funding and stuff, which complicates things. So when it's a when it's not a shockable rhythm, first rhythm is asystole, that's a criteria to say no for ECMO. And if it's going to be a difficult cannulation, like femoral access, obese patient, or previous femoral artery or femoral venous procedures in the past, so these are the things which precludes. And terminal illnesses, severe neurological impairment, either baseline or even with the resuscitation, we know brain is damaged a lot. And non-cardiac cause of arrest, it's no criteria. And if the patient is really frail, patient may be like 30 or 40 years, but if they are frail from any other significant disease, again, they are not for ECMO. And even if they don't meet the criteria, if they meet this physiological criteria like severe metabolic acidosis, severe hypoxia, and low capnography like end-tidal CO2, they are not a candidate for ECMO. So this is my local protocol. So this may not be asked in the exam, but this is the theme across different hospitals. There is no central fixed guideline for this. Each center has its own recommendations and protocols. So this is the area of improvement. It may come up in a big way in the future. Even in India, I see like a lot of centers doing like it. Very few centers like ECMO centers they are doing this and are showing good outcomes. So this may be part of your exam as well. Right. So coming back to our patient, this is the 12 lead ECG which we have got. So who wants to interpret this? Come on.
Okay, this should be an inferior MI.
Inferior MI. So what are the findings? And if anyone want to add to the John's answer, please be welcome.
With posterior extension.
Exactly. Why do you say that with posterior?
ST depressions in V2 and V3.
And so what are the findings you see? Can you just tell the findings you are seeing? Like ECG changes. Let's discuss that through.
So it is a 12 lead ECG for heart rate around some 60 with a regular rhythm, sinus. There are ST elevation in 2, 3 AVF and then lead 1 even. And there are ST depressions in V2, V3, V4. And yeah. So inferior leads ST elevation is inferior MI with deep ST depression V2, V3 sometimes can significant for posterior MI.
Yeah. This patient, you are correct, bang on. So with suspicion of posterior, so had a posterior lead as well, which is showing like 7, 8, 9, which is in the back, which is showing ST elevation. So this is inferior and posterior, quite extensive STEMI. Yeah. So we can discuss the ECG and STEMI criteria. If anyone want to go, like what's the definition of STEMI based on ECG? Like what is the criteria? If for saving time, we can just talk through it. So any leads more than 1 millimeter, if it's V2, V3, in women more than 1.5 millimeter. In men, based on age, it's either 2 millimeter or more than 2.5 millimeters just for V2, V3. And STEMI equivalents, which we need to be aware of as well. So what are the STEMI equivalents? It's given there, but if someone can talk through it. Have you had any experience with STEMI equivalents?
Yes, sir.
I've
What
not
is
had
it?
experience, but I have an idea of where they are.
Yeah. Yeah, go ahead, John.
Okay, like T-wave inversion and this left bundle branch block, new onset left bundle branch block is
Yes.
also thought.
Valence and all.
Yes, yes.
Well,
Wellens syndrome,
yeah.
where the STA is it's wavy. ST depression, not I don't know how to describe it now. But this Wellens syndrome, they are all STEMI equivalents,
Yeah, valence doesn't strictly come under STEMI equivalence, but it's something suggestive of like proximal LAD or left main obstruction and needs to be investigated quite soon, but it's not like a STEMI which needs to go to the lab immediately. So they can take some time to stabilize the patient and then consider angiogram. But these are the STEMI equivalents like posterior STEMI and LBBB. If the patient is known left bundle branch block, how would you say like they are having like STEMI or STEMI equivalent?
Garbo criteria. I need to take Garbo criteria. There are three components in that. So concordant ST elevation or concordant ST depression of 1 mm in anterior leads.
Yeah.
And in any discordance of ST elevation of more than 25% of preceding S wave, that is also considered as a Garbus criteria. That is a modified Garbus criteria. Any of these particular recent findings that can consider as a new STEMI in a existing LBBB.
Yes. And T winters pattern, like all symmetrical T waves.
V2, V3.
Yeah. In that chest leads, again, suggestive of STEMI equivalent. And within the posterior STEMI, so these are the other things like horizontal ST depression, which we mentioned, dominant R wave in V2 with upright T wave, like dominant R wave with upright T wave. So this combination is more suggestive of a posterior STEMI. Right. So our patient, based on this ECG, is transferred to the cath lab urgently. Coronary angiogram reveals like proximal RCA occlusion with severe triple vessel disease, but the cardiology think RCA is the culprit lesion, so they have stented it. Again, this is based on evidence. They don't address all the vessels. If the patient is coming with STEMI, they just address the culprit lesion based on a recent trial and shift to ICU for stabilization. Then they go back to do a staged PCI later on. So this patient just had a RCA stent and during the procedure becomes unstable, responds to fluids, requires vasopressors, intermittent boluses. Currently, the patient doesn't have a central line, so no urine output, low GCS without further sedation. So the anesthetist inserts a central line and starts on noradrenaline, dobutamine, and transferred to the ICU. So in the ICU, at the end, they do an echo, and this is what they find. Can you all see the echo images?
Yes, sir. Yeah.
Yeah. Who wants to describe the findings? Any echo experts here? or even if you're not, it's quite obvious what's happening.
Yeah, in a short axis view, you can see the inferior and posterior wall is not much moving over there. No good contraction, and if you see in a apical view, you can find EF is also around some 40 to 45%, mild to moderate. And in a long axis view, you can see a little bit of hypertrophied left ventricle with no pericardial effusion and no clot.
Okay. Anyone else want to have a go? Or anything to add? Yeah.
Okay, let me add that in the parasternal long axis view, the mitral valves are performing very poorly. It's not opening very well. No, it's not reaching the interventricular septum at all. Just barely opening. And I will say that the left atrium may be not really dilated. It's an acute event, but I think I think that's most likely there is mitral valve prolapse.
Yeah. Anyone else? So you want to manage the patient based on these echo findings. So that's why it's important nowadays. It's becoming an essential skill for all the intensive care physicians. I'm actually doing a fellowship in echocardiography currently, advanced critical care echocardiography. So I can talk to you about this. So this is parasternal long axis view, right? The first one on the left upper corner. As John said, the mitral valve is not opening brilliantly. When it's normal, this is anterior mitral leaflet almost touches the septum. That's what we call key point separation. It's quite large. It's not moving near the septum at all. And even this is anteroseptum and this is inferolateral wall. It's not coming in at all. It's severe. The septum is akinetic. Even the inferolateral wall is akinetic. Only the basal part is moving in a bit. So just with this image, it's giving me an impression of severely impaired LV function. This is the short axis view. So we can see the left ventricular circumference. The lateral wall is not seen well, but if you see the septum, it's akinetic. The inferior wall is akinetic. It's kind of globally akinetic. And ejection fraction is definitely like less than 20%. It's kind of severe impairment, maybe 10 to 15 visually. With a subcostal view, so this is the left ventricle, left atrium, right atrium, and right ventricle. So here we are seeing the right ventricle here. So we are in this patient, it's a posterior STEMI, right? Predominantly RCA occlusion. So the right ventricle is severely impaired as well. If you see only the basal portion is moving in. So the TAP C, if we measure it, may be normal. But if you see the lateral wall and the apex, it's not at all moving. Again, there is regional wall motion abnormality in the right ventricle. So it's kind of severe biventricular failure here. This apical four chamber view, it's not a great view. We're not seeing the lateral wall and the right ventricle, but we are getting the impression like it's not doing much. So overall, it's severe biventricular impairment. Ejection fraction visually is 10 to 15%. Valves, we are not able to assess here, but that's the impression. This is enough for making our clinical management, right? So this patient is in shock and the heart is not doing very much. So we can confidently say this is cardiogenic shock. So now my question is, what is the definition of cardiogenic shock and how do we classify them? So now the patient has come to the ICU, right? So cath lab is done. Now back to ICU. How are we going to manage this patient? It is a simple question, but
Actually, this patient should be monitor hemodynamically in invasive monitoring. So maybe we'll insert the pulmonary artery catheter or
yeah, we are,
together with other.
how do we define cardiogenic shock? We will discuss the management next.
Shock due to LV dysfunction, causing hyperperfusion. I mean, yeah, any that can be called as a cardiogenic shock in its
Yeah,
broad way.
you're almost there. So shock and hypoperfusion based on a cardiac cause, not necessarily just LV. It could be RV as
Yeah.
well.
RV.
So actually, it's not that easy to define cardiogenic shock. Over many years, each trial had its own definition of cardiogenic shock. There was no simple like consensus on how to define it. So in 2024, this consortium, Shock Academic Research Consortium, I think it was published in Lancet, they sat together and brought like consensus. Okay, this should be the definition of cardiogenic shock. So all the trials can follow the same thing and it can be universally applied. Cardiac disorder is there and clinical plus biochemical evidence of sustained tissue hypoperfusion. So that's the definition they have brought together. Okay. For the purpose for trials, they have added a bit more specificity like systolic blood pressure of less than 90 for more than 30 minutes or requiring vasopressor or inotropic support to maintain a systolic blood pressure. And there is a caveat, even if the systolic blood pressure is more than 90, it can still classify under cardiogenic shock in a subset of patients where despite having a good blood pressure, patient is having poor peripheral perfusion. It is still possible the patient is in cardiogenic shock, but that's a small subset. And all the hemodynamic criteria based on like PA catheter or advanced cardiac monitoring comes optional. It's not necessary even for the trials. This is important because for enrolling people into trial, like in the early phase of cardiogenic shock, the definition needs to be simple. If they put in like multiple parameters just to characterize them as cardiogenic shock, no one is going to ever get enrolled into these trials. That's why they have made it like as simplified as possible. Okay, so how do we classify cardiogenic shock? What is recommended nowadays being used in multiple trials for classification or understanding cardiogenic shock?
You mean left ventricular, right ventricular failure? Or how it is classified? I have no idea.
Yeah, so forward failure, backward failure, left, right. So these were like which were taught in the school, like medical school. But nowadays in trials, we are using like more common terminologies. And if you have read about KILIP classification, it gives like cardiogenic shock, heart race, or based on their whether they're wet or dry, and whether they are cool or warm. There is another classification, but more standardized classification. Anyone have any idea?
Sky classification,
Yes,
Society of
exactly.
Surgical Angiography
Yeah.
and Intervention.
What's that, Imran?
Sir, that starts with the A,
Yeah.
that is at risk,
Mm-hmm.
and those are the people who don't have structural abnormality, but uh, they have some hemodynamic instability, but they don't have any uh, structural. Sorry, they have some structural abnormality, but they are not showing as of now any signs of hypoperfusion. B is
Yeah.
the beginning. There you have started having features of cardiogenic shock, but still they are
So they
very
are
mild.
still.
And then C is classical, then D is deteriorating, E is extreme.
Yeah. So what stage our patient is in now?
Classic.
Classic, yeah. So A is at risk. Patient is having like risk factors for cardiogenic shock. Like patient has come in with MI but currently stable, not hypotensive, not tachycardic, but he may become hypotensive. So at risk. B is no hypoperfusion, but some signs of tachycardia, hypotension. But perfusion is warm, well perfused, but hypotensive or tachycardic beginning. C is classic, requiring vasopressors to maintain a stable blood pressure or perfusion. So that's classic. D is despite treatment, patient is deteriorating. So that's D. And E is near arrest or peri-arrest or ongoing CPR, ECMO support like that. That is E. So our patient is in classic cardiogenic shock now. So now coming to mechanisms of shock in this patient and how will you manage? I think Mohammed Raha already started out speaking about how to manage. Do you want to continue, Mohammed? Or anyone?
Mechanisms of shock.
Yes.
يعني I don't know preload. How is a preload? Impaired pump and left ventricular function.
Yeah.
If they need monitoring and mechanical support, mechanical cardiac support.
Yeah.
We assess volume status of the patient first. If
good.
patient need the volume, then we can start vasopressors and inotropes.
Yeah.
Then we will think for mechanical support if ECMO or or venting with Embella or something.
Yeah. Anything else?
Sir, for the mechanism.
What's that?
IABP?
IABP. It's
yes.
Part of the mechanical support devices. Yeah. Anything else?
So, sir, for the mechanism of shock in this patient, I think because it's a RV involvement, so it will be mainly RV failure, causing decreased blood flow to the lungs and eventually towards the LV, leading to the poor ejection poor stroke volume. And secondly, because it can also involve SA node, so bradycardia can be a mechanism of shock in this patient.
Yeah, interesting. Yeah, very good. Yeah. If the patient is bradycardic, that can again lead to shock. Yeah. Anything else? So actual examiner will just say like anything else.
Actually, you should exclude other causes of shock, other types of shock like obstructive shock or
mechanisms of shock in this patient. We know he is in cardiogenic shock, but is there any other possibility? Like what other mechanisms can be there in out of hospital cardiac arrest?
Adrenocortical insufficiency also?
Yeah. So this is how I would have answered. Like we know he is in biventricular failure. So LV failure is significantly contributing to the shock. RV failure as well. So as we said, could be preload dependent. We can try with some fluids. And we discussed the interdependence because of RV failure. There is no adequate output preload to the LV. So LV is not having enough ejection. That is correct. And even if RV is distended, it can cause interdependence and cause compression of the LV, can cause interdependence LV failure. And even if the PCI is successful, the patient can go into kind of stunning because of cardiac arrest, defibrillation, and reperfusion injury. So it takes some time to recover from that shock. So that is often the reason for like out of hospital cardiac arrest having severe LV dysfunction, even without having like coronaries problems. Even with minimal coronaries, some of the out-of-hospital cardiac patients can go into myocardial stunning and cause transient global dysfunction. So this patient had like severe biventricular and global hypokinesia or akinesia. So it's possible this patient is in stunning and may recover if given time and time to recover. Yeah. And other possible reason can be like SIRS response. Just with any type of cardiac arrest, the patient can have a SIRS response and be vasoplegia. So that's why we need to have like advanced cardiac monitoring and titrate based on the SVR and afterload. So yeah. Although it's obvious this patient is having severe LV dysfunction, these are the possibilities, mechanisms of shock. So that's going to change our management, right? So we discussed some of it. So first of all, we need to have some answers. What is the cardiac output? What's ejection fraction? We need precise answers. So we need a formal echocardiography. This patient will make a case of PA catheter, definitely because RV is failing. So we need a PA catheter to help guide us with the therapy. Or if you have had about like PICO, pulse counter analysis, it usually uses the femoral arterial catheter and uses thermodilution technique to get cardiac output numbers, to also give some SVR, global end diastolic volume, intrathoracic blood volume, extravascular lung volume. So it's quite a useful hemodynamic parameter, monitoring, but has its own disadvantages like with PA catheter. So we need some advanced cardiac output monitor, definitely based on whatever is your availability. So we need to definitely discuss that. And so coming to the management, now we need to focus, like in cardiac anesthesia, we would have been taught about cardiac grid. How do you manage the heart rate, preload, afterload, and contractility? So these four things we need to focus. So preload, since it's an RV infarct, they may initially respond to a bit of fluid, but we need to be really cautious with the fluid management with close monitoring of the CVP and pulmonary artery pressures. And vasopressors, noradrenaline is now the first line of choice for irrespective of the kind of shock, right? Irrespective of whatever the shock is, just start with the noradrenaline. But if the noradrenaline requirement keeps escalating, then you need advanced cardiac output monitoring, echocardiography to see how do we play with the afterload and preload and contractility. So this patient is definitely going to need some minotropy, either dobutamine or milrinone. We need to decide. And reducing the afterload is going to be helpful as well, especially with the severe LV dysfunction. If we keep going up with the NORAD, like 0.5 or 0.6, the LV is going to struggle even more because it has to work against increased afterload. So it makes sense to reduce the afterload by adding in milrinone, or dobutamine, which decreases the afterload and increases contractility as well. And this patient is being ventilated. One thing to keep in mind is avoid high airway pressures. We just need to aim for normocapnia. We don't need to hyperventilate them or give excessive PEEP, which the RV doesn't like. LV function, just if it's isolated LV failure, adding positive pressure and PEEP might be helpful, but not so much for the right ventricular function. And of course, maintain sinus rhythm. Yeah, they are not going to tolerate bradyarrhythmia or tachyarrhythmia of any kind. So you'll try to maintain sinus rhythm as much as possible. Other thing which we can consider here is if the PA pressures are very high, but with severe we can think of inhaled nitric oxide, but again, that won't be possible in the setting of biventricular dysfunction. Just for discussion sake, I'm putting it out. Any doubts with this? Otherwise, I will move on. So this patient has come to the ICU now with worsening shock, loaded with dual antiplatelets, aspirin and ticagrelor. Heart rate is high, BP is still low. NORAD is 0.4. Since tachyarrhythmia is there, you switch to milrinone, which improves things with the heart rate. MAP of 62 now. Still peripherally hypoperfusing. Lactate continuously going up, like went up to 9.1. Urine output is very low, oligonuria. So PA catheter is inserted. Cardiac index is 1.5 liters per minute per meter square. Mixed venous sats is 45. CVP is 18. PA is 25. Pitch pressure is 20. So urgent cardiology review is requested. So what's happening here? So from psi C, so this patient is kind of moving into psi D, right? This patient is deteriorating despite giving inotropes and vasopressors, fluids, continuously deteriorates. So that's why you are called the cardiology. So now we are discussing about the mechanical support devices. What options are available? Somebody mentioned about IABP. What are the other options available? I think we mentioned ECMO as well. We just need one more mechanical
Impeller
support.
device. Impeller device.
Of course.
Left ventricular support device. Yes.
Yeah. So these are the three kind of support devices available. Have any of you worked with impeller, or your centers using impeller?
I have seen only one case with impeller.
Okay. So what is the evidence with all these devices separately if we discuss? Any ideas with the evidences for these supports? Which is having some benefits, or does it have any benefits at all?
Impeller shows some benefit, but I forgot the name of the trial. And I have seen one case of impeller, not many.
Yeah. So I've given the trials here as well. So with IABP, so recent trial is IABP shock, specifically done in like cardiogenic shock secondary to myocardial infarction. There is no mortality benefit at all. But we still use a lot of IABP to support like high-risk cabbage or high-risk PCI perioperatively just to support. We are using it. I don't know how much beneficial it is, but it is being used. And other support is VA ECMO. Again, ECLS shock and ECMO cardiogenic shock trials didn't give any positive outcome, no increase in mortality benefit. So again, still being used occasionally for even with this. So in the form of ECMO CPR, now it's coming up, the use of VA ECMO. And often we sometimes mix impeller with VA ECMO. In the cases of ECMO for venting, the concept of LV venting is there. ECMO basically increases, the VA ECMO specifically increases the afterload for the left ventricle. So the left ventricle can get distended. So we need to offload the left ventricle, and this microaxial flow pump like impeller comes in really handy. Even otherwise, without ECMO, so now the impeller is having increasingly more evidence. And the recent danger shock. So it's called danger because it was done in Denmark and Germany and one center in UK. And it has shown really good mortality benefit. Number needed to treat is 8, which is very low. And rarely we get some intervention which is showing like mortality benefit in the intensive care, right? So that's why there is a shift towards moving from IABP to impeller. In my center, definitely I'm seeing more and more cases of impeller being used. It is very expensive, so it's not available everywhere, but selectively being used in multiple centers across the world, and it's showing some good outcomes as well. So it's going to be the future, I think. So we need to definitely know more about Impella. And Impress is another trial which showed some mortality benefit as well. Interestingly, in the danger shock trial, although it improved the mortality, it also caused significant adverse events like limb ischemia and multiple stuff, which we will discuss. So our patient went back to the cath lab, had a Impella CP device inserted. So there are like few varieties. CP is commonly used, and post insertion, cardiac output improves, the vasopressor requirement is coming down, lactate begin to fall, but the hemoglobin is dropping and LDH is rising. So we'll come to our case. I will take this time to explain you how the Impella works. So it's like IABP, we insert it through the femoral artery, and through the femoral artery, it goes through the descending thoracic aorta, across the aortic arch, into the LV, right? So this is a pigtail tip, and this is a microaxial pump. So if you zoom in, so this is the actual motor, basically sucks in blood from the left ventricle and pushes it out into the aorta above the level of aortic valve. So basically it sucks in blood from here and pushes it out here. So the LV doesn't need to function at all. It does all the work. So it is kind of non-pulsatile flow, and it works within like a coaxial system. That's why we call this coaxial support device. So not only for the left ventricle, there is similar device for the right ventricle as well. So here, if you imagine this is the right atrium, right ventricle, and this is the pulmonary artery. So it sucks in blood from the right ventricle and pushes it out delivers it into the pulmonary arteries. Similar mechanism, but just the direction is different. So currently in UK, we have this Impella device, which is being used commonly. The more important side effect problem with the Impella is, as you can see, this has to be placed precisely just above and below, the inlet being below the aortic valve, outlet being above the aortic valve, and this pigtail shouldn't get caught within the mitral valve apparatus. So it has to be placed accurately and monitored frequently with echocardiography. So that's the important thing with Impella. And it has like a propensity to clot like IABP, so we need to be anticoagulated, and this motor may get clot with, may get thrombosed. So it has a purge bicarbonate infusion which has to run. Like for any arterial line, we give a pressurized bag, right? So like that, even Impella has a pressurized bag and bicarb solution is infused through it. So coming back to our case, so my question is why the hemoglobin is dropping and the LDH is rising?
Why is it
Hemolysis.
because of mechanical thing?
Yeah, and why hemolysis?
Because the blood has to go through a pump, and the RBCs get, because of the turbulent flow, they get damaged.
Yeah. So usually there is increased turbulence, but the risk of hemolysis increases when it is abnormally like misplaced. When it's not in the right place, the risk of hemolysis is very high. So if the patient is hemolyzing, we should monitor like twice daily or hemolysis bloods. And if it's hemolyzing, it's a sign like the Impella pump has moved in or moved out. It's not appropriately placed. So we need to troubleshoot it. So what are the other complications associated with this device or any mechanical support devices which uses a groin axis like femoral arterial axis? We already discussed. Sorry?
Limb ischemia?
Yes, that's one of the important side effects, adverse events. Others?
Femoral artery dissection, pseudoaneurysm.
Yeah, vascular injury.
Thrombocytopenia.
Yeah. Anything else?
Microthrombi formation.
Mm-hmm. We have some crosstalk. You'll ignore that. So we discussed hemolysis, we discussed vascular injury, limb ischemia, device malposition, bleeding risk is always there, and infection risk is always there as well. So these are the pretty common complications associated with impella. Device malposition is a big problem. Maybe later I can show you. You can search for like impella position in echo. It should be like faced. This device tip as an angle, like this angle is there. Actually, this is not appropriately placed. This angle should be facing, pigtail should be facing towards the apex and towards the septum, not towards this wall. And it should be avoiding the mitral valvular structures, not getting caught within this. And based on the device, it should be like 3 to 4 centimeters from the aortic valve. The inlet should be placed 3 to 4 centimeters from the aortic valve position. If it's too far in or too back, then it's going to be a problem. So positioning is important with the impella device. So we have crossed day 5 in ICU. Impella, we have started weaning. Again, we will discuss in another class about the settings of impella and the troubleshooting of impella. So the vasopressor requirement is coming down, but the patient remains comatose. EEG shows burst suppression. NSC is elevated. So obviously the patient is having poor neurological prognosis. Finally, you may get a question about like this. How do you perform neurological prognostication? So now we have crossed 72 hours. We have discussed few techniques already, but what are the other methods we can neuroprognosticate? Just to summarize.
Somatosensory evoked potentials, MRI brain,
Mm-hmm.
brain stem reflexes.
Yeah. So just to summarize, so our clinical examination is the most important thing. Then we have CT scan, MRI brain to assist us prognosticating, biomarkers, EEGs, SSCPs. If it's clear like brainstem death, no absent pupillary reflexes, absent brainstem reflexes, it's easier. But we often get stuck in the place where the patient is having the reflexes, having a low GCS, but not really making any meaningful recovery, stuck for like few days. That's when it becomes tricky to prognosticate, right? How do you prognosticate them with the family and move forward? So that's when we need the help of MRI, EEG, and neuron-specific analyze. If it's elevated like significantly, it can be abnormal, but the cutoffs for the neuron-specific analyze are not very clear. Most guidelines say like more than 60 is abnormal, but it's not very clear. If it's really low, it's a good prognosticating sign. But if it's high, we are not sure exactly how important it is. And the somatosensory evoked potential is useful in brainstem death. Like if the patient is having some recovery, but not entirely brain dead, it doesn't offer much apart from like MRI, and in addition to MRI and EEG, it doesn't offer much information. So EEG and MRI definitely plays crucial role in places where it's not very clear, like if the patient is going to recover or not, and decide based on that whether we go for withdrawal of life support treatment or continue carrying. Depends on country rules and palliative pathways, we can then decide. So that's a summary of neuroprognostication. So I've tried to cover out of hospital cardiac arrest, prognostication, STEMI, mechanical support devices, cardiogenic shock, This is how the actual exam looks like. They don't fit in like a single system. A single patient may have multiple problems, like in real life scenario, and how are you going to manage that? Like in the same patient, we can discuss about AKI or CKD. There can be multiple branches of questions. So that's how we need to be prepared. Like for a real case, how things are going to progress and how they are going to end up in ICU or die, or how do we deal with that. There may be ethical questions, communication questions with the family. So you can expect all these kind of questions. I think that's the end of it. Today's class. If you have any questions, feel free to ask, or if you want to go back to any question, we can discuss it again. Sorry, I slightly went more than 1 hour, 1 hour 20 minutes. I didn't realize that. But if you have any questions, feel free to discuss. I hope this was really useful for you.
I have a question.
Sure.
For how many days you can keep the impella inside the body?
Right. So there is no clear guideline on that, but they are not keeping more than 10 days. So it is being used like a bridge to recovery or bridge to diagnosis, but not more than 10 days. I think it's licensed for only 10 days.
And do we anticoagulate like other mechanical devices like ECMO and CRRT like similarly, or is it different from those?
Yes, the patient needs anticoagulation of some form, like whatever the method, like infusions. Heparin infusion is preferred because of the increased bleeding risk, but yeah, they definitely need some anticoagulation.
Thank you.
Hello, sir.
Yeah.
Sir, the one case I have encountered, he had a severe metabolic acidosis, same anterior MI case. So we started him on CRRT also. Initially, he was on high inotrope support, including adrenaline. Later on, slowly everything has been tapered by day 5. On day 7, he had again another episode of VTAG and VFib, and this time he couldn't revive. So,
Okay.
is this a common problem for any other patients who are about to recover and again suddenly can have another episode of MIs, and how frequent it is?
You mean the risk of arrhythmia is high in these patients, or risk of
Yeah, risk of arrhythmias. Yes, sir.
Yeah, these patients are generally too unwell. Basically, they wouldn't have survived if not for this robust CPR or like cath lab. If it's not there, they are not going to survive, right? So somehow, because of improvement in medical facilities, these people are surviving enough to like live and recover from the MI and then have hypoxic brain injury, and so they are like severely ill population, so they can develop n number of complications, not only arrhythmias, even after growing through. Like I've seen patients coming off impella, coming off ECMO, then finally found to have like weeks later severe neurological injury, then withdrawn, or they may have like severe bleeding episode from GI bleed or catastrophic intracranial hemorrhage in the later stages. So they can have all sorts of complications. The mortality remains very high despite all the improvements, but with future medical advancement, I think it's quite useful to have these devices which gives them a chance to recover. Yeah, some of the patients do survive.
Okay, sir. Thank you.
So yeah, this is you must have got the idea like how the exam is going to be. This is exactly how the exam will be. Like they can be like multiple scenarios, branches, pictures, videos. So you can expect actual clinical case kind of scenario. There can be some rare complications which are asked in exam as well. So we can never predict how the exam is going to go. All we can do is answer in a structured way and try and answer as much as possible. We may think the answers are like really simple, but still it may carry a point. So put it out. Don't take too much time as also like trying to answer in a comprehensive way. Be structured and focused. So don't take too much time just talking. The examiner may be expecting a different thing. So go with the lead of the examiner. If they are like saying stop, that's enough. Stop it. Then just focus on what's the question that is being asked you. Right? All right. All the best. If there are no more questions, we can stop the session. And all the best for your exams.
Yeah. Thank you, sir.
Thank you, Dr. Arun.
Thank you.